Welcome to the Low Carb MD Podcast. No one is beyond help. No one is beyond hope.
As we've always said, we're bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor.
Guys, welcome back to the Low Carb MD Podcast. We have the Titan is back. Okay, one of our regular co-hosts coming back. It's Dr. Jason Fung, author of the Diabetes Code, the Obesity Code. You guys all know him. And he is here to talk to us about his new book. I'm super excited to get my hands on it and start reading it, The Cancer Code. I cannot wait. I cannot wait to read this. And there's so much controversy about diets for cancer. So I'm glad that you're making sense of it, Dr. Jason Fung.
Hey, Joe, great to see you.
Thanks for coming on and coming back. And yeah, can you tell us when does the book come out and what should we expect?
Yeah, so the book is out November the 10th. This is a little bit different from some of the stuff that I've written in the past. I got into it from sort of an obesity angle, sort of metabolic disease angle, but the story turned out to be far, far more interesting than I had originally anticipated. So it actually covers not just the sort of link between nutrition and cancer, which is an interesting topic by itself, but really gets into the deeper topic of what is cancer? Like, what is this disease? Because the entire way that we look at cancer as a disease has actually shifted within the last sort of 10 years. And the story of what we believe cancer to be is actually far more interesting than I had sort of anticipated. So that's what this book is sort of about. Like, what causes cancer? Why does it develop? And how to think about this sort of paradigm of cancer. And that's really the sort of first part. And then I go into nutrition and cancer, what makes it the cancers progress, and the sort of seed and soil way to look at cancer. That is, we've looked at the genetics of cancer for the last 50 years. But what we haven't appreciated quite so much is, just how much the environment contributes to that. That is, if you look at native populations, when you talk about sort of Western diseases or diseases of civilization, cancer was always one of those diseases of civilization. I mean, it doesn't happen in a lot of these traditional societies. So it's not simply the genetics, which is what's important. It's the environment that you have. So even if you have the seed of cancer, it's the soil that allows it to flourish. And what is it about the soil in our modern day society or civilization or Western civilization that really makes it much more likely? And then sort of how this new paradigm of this sort of evolutionary paradigm of cancer translates into sort of the new treatments and what is available currently, which is sort of immunotherapy. So it sort of takes us through the history of cancer. It's not so much a disease. It's not a book like, how to prevent cancer. That's not really, it's not easy to do. And it's not a book about, how to cure cancer. Again, it's not easy to do. And it's more of a story of, sort of where we're coming from and where we're going in the future with this disease.
Yeah, I'm actually really excited to read it and to be part of that story, because I know that the medical paradigm, the way it views cancer is, there are these bad cells, they're multiplying, and we don't really know how they got there. Maybe it's genetics. Maybe we'll look at the types of cells under a microscope and stain them and look at the genetics, and it's like, if they're this gene or that gene, if it's P53 or this, we're going to give you a different therapy. It's all kind of geared towards therapy. And I wish somebody would say, how the hell did we get here?
Yeah, that's exactly the question that I am trying to answer. And, the way I put it out is that there's really sort of, in terms of modern paradigms of cancer, There's really three, and we're sort of in the midst of transitioning to the third one, which is really important because I think what you're talking about, which is the paradigm we've been in, which is, oh, you have this cancer, let's look for all these genetic mutations and see if we can develop drugs to target these genetic mutations. And the hard truth is that that's been spectacularly unsuccessful for the last 20 years. Like, we thought it would be great, but it hasn't been great. And that's why we need to move to a sort of deeper understanding. So what the book basically goes into is the sort of the first paradigm of cancer was the first modern paradigm of cancer anyway, is that this disease is a cell that grows too much. And it's really interesting because cancer, sort of alone amongst the common diseases, is a real mystery, because for a lot of the diseases, we know what causes them. So you have COVID, you have a virus, right? If you have, an infection, you have Staph aureus or what other bacteria. You have a heart attack, you had a blood clot, narrowing of the artery, you didn't get enough blood, and that gave you a heart attack or stroke, right? So we know a lot of these diseases, common diseases, what they are and what causes them. But what is cancer? Like, what causes it? We have no idea, because this is a cell that was originally part of your own body. Like, it wasn't some kind of foreign invader, and it's kind of going out of control. And why? So that was the first sort of great paradigm of cancer. This is a cell. It's a disease of cells. And it's a cell that just grows too much for some reason, right? And that was sort of from the 1800s right up until the sort of 1970s. And by looking at it as a disease of too much growth, now you can say, well, if it's a disease that has too much growth, what's the answer? The answer is to have things that kill, right? So ways to kill cells. So you started out with surgery. So, that's probably the most ancient treatment in the world. You just cut it off, right? And then in the 1900s, we had radiation. So we're looking at different ways to burn the cancer. And then in the 1940s, we started to develop chemotherapy, which are basically selective toxins. So they're poisons that kill cells, and they kill cancer cells slightly faster than they kill normal cells. That's the whole premise of chemotherapy. They basically try to selectively kill cells, but they are poisons, like, make no doubt about that. So what you had was these treatments, surgery, like cutting, burning, radiation, and poison, which is chemotherapy. And that was the logical sort of answer to this paradigm of cells that grow too much, let's find ways to kill cells. And that's not to minimize it. These are still the treatments that we use today. They're like the backbone of almost every oncology center, is surgery, radiation, and chemotherapy. But it starts to reach a limit, because you get a limit in the 70s, you start to reach a limit as to how much further you can take this paradigm, because you don't understand the disease to its core. That is, you have cells that grow too much, but what is causing the cells to grow too much, right? That's the real question. And so we knew about things that cause cancer. So we knew tobacco smoke and asbestos and certain viruses, for example, hepatitis B, hepatitis C, human papillomavirus. We knew viruses cause cancer. But what was the sort of link between them? Why did this virus, for example, or tobacco smoke, why did it lead to a cell that grew too much? We just didn't know that. And we started to get an answer in the 1970s. And this was through the genetic revolution. We worked out the sort of structure of DNA. We figured out genes and chromosomes and all these other things. And we said, oh, here's the answer to that question, this deeper question of why are these cells growing too much? It's because of genetic mutations. So tobacco smoke, for example, which causes cancer, it leads to genetic mutations, which cause the cell to grow too much. And viruses also lead to genetic mutations, which cause cells to grow too much. And so this is a sort of unifying theory, and it really made a lot of sense. We went to look at the cancers, and sure enough, there's mutations sort of everywhere that you look. And then they said, well, why are they causing these specific mutations? And we said, well, if you cause a mutation in a gene that's responsible to growth, then you're going to get increased growth, which is the whole point. But tobacco smoke is not selective. It doesn't target just growth genes, for example. So we said, well, it's just that there's a random chance that this tobacco smoke caused damage to the DNA, which caused mutations. And the more mutations you have, the more chances you are that it's going to hit upon this growth sensitive area, and then you're going to get excessive growth. So this paradigm, the sort of the second major paradigm we came to was this genetic paradigm of cancer, which didn't invalidate any of the first paradigm. That is, it's still a cell that grows too much, but you're sort of going one level deeper into saying why. Why are the cells growing too much? And it's because of these genetic mutations. And so through the 70s, 80s, and 90s, we started to work on this genetic paradigm of cancer. And then the first drugs started to come out because really the effectiveness of a paradigm is to lead to effective treatment for the patient, because that's really what we're interested in. And the first few drugs that came out were just spectacular, like really, really amazing. So we had imatinib, which was for CML, which is chronic myelogenous leukemia. And the thing was amazing. It basically cured the whole thing. It was ridiculously good. Came out around 2000, and it was CML was a minor disease, but instead of looking for ways to kill cells, this was something completely different. This was a way to fix the genetic mutation, right? So you had the BCR-ABL gene, and you're going to fix this mutation, and it was crazy good. And then shortly thereafter, you had trastuzumab, which was for breast cancer, HER2 positive breast cancer, and again, crazy good results. The drug was just, again, you're not trying to kill cells, you're trying to fix a genetic mutation which is leading to the cancer. And in this case, they went even further. They said, whoa, not all breast cancers have this genetic mutation, so we're actually going to figure out who needs it and then only give it to those people who need it. And that was, I remember thinking about it at the time. It was like, this was mind-blowingly amazing. And this was sort of the promise of personalized medicine, right? You're going to figure out who needs this drug and targeted therapy. So personalized precision treatment, which was sort of this holy grail we had for cancer treatments. So by the early 2000s, we thought we were on the edge of beating cancer. Like the optimism was high. Yes, these drugs were expensive, but we had all this technology. So we basically went down this pathway of genetic mutation, this genetic paradigm of cancer. And then what happened, of course, was that we needed to figure out the roadmap. So there's this Human Genome Project, which came around, we're going to sequence the entire gene of one human being. That was the big project, and it took millions of dollars. And so we were like, okay, let's do this. And in 2000, they finished the Human Genome Project. But the problem was we weren't any closer to finding a roadmap for cancer, right? So we thought we could say, okay, let's find the 2 or 3 or 4 mutations in each cancer. So let's take colon cancer. Let's find the 2 or 3 or 4 mutations in colon cancer, develop some drugs, and then we'll just treat it. We'll do the same thing for lung cancer. We'll do the same thing for myeloma. Boom, we're going to be in a cancer-free world very soon. It didn't quite work out that way in the Human Genome Project. And then, so they sort of doubled down on this genetic paradigm, and we did the Cancer Genome Atlas, which was, instead of sequencing one human being, we would sequence, I think they wound up with 33,000 tumor samples. So they would do the genes of all of these tumors so that they could compare them. Because the technology had advanced so much. I mean, honestly, in 2000, it took like $100 million to sequence one person's genes, and probably you or I could do it for $100 today, right? You go to a lab and you probably get every gene sequenced at 23andMe or something for like $100. So the technology had advanced so much that we could sequence sort of thousands and thousands of tumor samples. And then we thought, okay, well, this is it, right? This is going to reveal those 2 or 3 or 4 mutations in each cancer, and that'll be it. The problem, of course, which we found when we did the Cancer Genome Atlas, was that there were not 2 or 3 or 4 mutations. Instead, if you take a cancer like breast cancer or a colon cancer, it was like 50 or 100 mutations. It was way more than we thought. It was way more complex than we thought it was going to be. So if you took a breast cancer patient or a colon cancer patient, and yeah, patient A, he had 100 different mutations. Well, you're not going to be able to develop 100 drugs for this one patient. It's just not going to be possible. Each drug takes like forever. But the problem was that patient B in the chair next to him had 100 mutations, but 100 different mutations from patient A, even though they looked identical from a clinical standpoint. And patient C had 100 different mutations from that. So it was complete genetic bedlam. So at last count in 2018, when they catalog all these different mutations they found in cancer, they came up with 6 million different mutations that have been found in the different cancers. So this sort of paradigm really started to fizzle because you simply can't do one or two drugs. You need hundreds of drugs, and who knows if that'll even work for, even if it works for one patient, it may not work for the next patient. And that's sort of when things sort of hit rock bottom by about 2010. And the whole genetic sort of paradigm sort of fizzled. The number of drugs that were coming out that were truly going to make a difference to this had basically dried up. There was really very little. And if you look at some of the studies that came out, or what they found was of the sort of 15 or 17 drugs that were, approved, the average survival in cancer improved by 2.1 months. Right? So almost no improvement in overall survival. That is, if you were, say, an 80-year-old man who developed cancer, if you took this very expensive drug with side effects, you could live, to 85 and you're 80 in 2 months or something like that. It's hardly worth it. Like, you're going to sell your house and bankrupt your kids' futures for the extra 2 months. It's ridiculous. The prices were going up. The drugs weren't coming in, and that was sort of the rock bottom. And that was sort of very promising, and that's sort of where a lot of people still think we are. But the interesting part is that we've actually started to move into the next paradigm, which is, again, trying to take this genetic paradigm and saying, yes, there are genetic mutations that cause too much growth. But again, what is it that is causing these genetic mutations? Because the point is that these were not random genetic mutations. They're actually specifically targeted. Like, cancer cells are different from regular cells in a very specific way. And they've been codified in one of the sort of most famous papers in oncology, which is the hallmarks of cancer, by very specific ways. That is, to simplify it, cancer cells grow where normal cells don't. Cancer cells are immortal where normal cells are not. They move around like the metastasize where normal cells do not. And they use glycolysis as opposed to normal cells that use oxidative or phosphorylation. So they generate energy in a different way. So these were very targeted mutations. That is, every cancer is not randomly mutating like we thought with the sort of genetic paradigm, the somatic mutation theory. It's not a bunch of random mutations. It's actually guided towards cancer. But why, right? That's the real mystery. And there's only one reason, there's only one sort of force in the biological universe that has the ability to coordinate mutations towards the sort of phenotype, like taking the genotype and coordinating towards a specific phenotype, which is cancer, of course. And that's evolution. So cancer is actually an evolutionary process. And this is hard to understand because you'd say, well, why is your lung cell trying to evolve towards a lung cancer cell, right? That doesn't make any sense. That lung cancer is going to kill you. And that's where the story gets sort of really, really interesting, because what people did was they looked back and they said, they brought in these scientists and they said, okay, so the National Cancer Institute in the late 2000s said, okay, we're not getting anywhere with this genetic mutation. And so I'm going to ask some other people other than these cancer researchers, because cancer researchers, all they want to do is go and look for more genes, right? And we're not getting anywhere with this. So they actually brought in a number of other scientists, so physicists, and they brought in this fellow, Dr. Paul Davies, who's an astrobiologist. So he studies life on other planets, right? And he says, I know nothing about cancer. And they said, good. You're exactly what we're looking for, because we need some fresh eyes on this. And so when he looked at the problem, he said, I'm immediately struck by sort of two things. One is that cancer is a very old disease. That is, it's not a human disease. It actually goes way past humanity. So if you're looking for human genes, you're not going to find the origins of cancer. It's actually embedded way far back into an evolutionary time, right to the beginning of multicellular life forms. Because if you look, dogs get cancer, cats get cancers, rats get cancers, and even if you look at Hydra, which is this tiny microscopic animal, it actually gets cancer. So why is it? And therefore, the second thing is that whatever it is, it's so fundamental to it's something fundamental to the way multicellular life arises. And it goes way back into the evolutionary past from how it evolved. So they said, well, if the important part is this sort of junction between unicellular life and multicellular life, what's the difference between a cell that is only a single cell and a cell that is part of a multicellular organism? And they said, well, if you look at the differences between those, there's actually a huge fundamental difference between a single-celled organism and a cell in a multicellular organism. That is a bacteria. So this bacteria is a single-celled organism, and a human being has multiple cells all over the place. Well, one, single-celled organisms tend to grow. That is, they grow and they grow and they grow, and they basically don't stop, right? And that's fundamentally different from a cell, like your liver cell in a multicellular organism, because your liver does not keep growing, right? Your lungs do not keep growing until your head pops off your shoulders, right? It has to stay the same size because it needs to cooperate with the other cells. The second thing is that bacteria, single-celled organisms like bacteria, they're immortal. That is, you can keep replicating them forever. If you take a flask with, some kind of bacteria like Staph aureus, you can keep replicating. You can't do that with a normal like lung cell or liver cell or breast cell, because it will stop after a certain number of divisions. That's called the Hayflick limit, and it will stop. The cell lines in our bodies are not immortal. The cell line in a single cell are immortal, and cancer cells are similarly immortal. And single cells move around because they want to go wherever they can go to find food. Whereas cells in a multicellular organism are stay put. That is, your lung has to stay in the lung. It can't just go around and hop off and go to your knee, right? So the way that cancer cells differ from normal cells is exactly the same way that single-celled organisms differ from cells in a multicellular organism. That is, the priority of that cell has changed when we did that huge evolutionary jump to multicellularity. Cells had to go from competition, they competed with other cells, to a state of cooperation where they're cooperating with the other things. But importantly, that old competitive sort of kernel never got erased. They simply added on sort of extra programming. So the sort of cancer subroutine, the kernel at the bottom, the sort of survivalist kernel, is still there. You simply added things on top to subvert them so that they are now cooperative, right? So there's a very fundamental difference between cells competing and cells cooperating. So it's what it kind of winds up being is that why are cells turning into cancer? And they're evolving, but not forwards. It's not a forwards evolution. It's sort of an evolution backwards in evolutionary time towards this sort of cancer, this sort of most fundamental core of cancer. and it's probably a response to chronic sublethal damage. That is, anything that causes damage to the cell, whether it's tobacco smoke, whether it's chronic inflammation. So you know that gastroesophageal reflux disease, for example, which is a completely natural substance, stomach acid, causes metaplasia in the esophagus, which causes esophageal cancer. Anything that causes chronic damage, radiation, which is a treatment for cancer, causes cancer. Chemotherapy, which treats cancer, causes cancer. Chronic scarring, you can get cancers at sites of sites of the surgery, the surgical margins, and so on. Anything that causes cirrhosis causes cancer. So any kind of chronic inflammatory damage, what it does is it now creates a selective pressure, because when you're talking evolution, you're looking for those selective pressures. And it's a selective pressure because that chronic damage means that that cell, if it continues, will die. But what it does to survive is start to evolve towards a simpler, more primitive form, which is that sort of single-celled organism, which is fascinating because that's actually exactly the terminology that pathologists use to describe cancer, right? Dedifferentiated, primitive, blast cells. So this is not a forward evolution. It's a sort of backwards evolution towards a more primitive form. And that answers actually so many questions about cancer. That is, why is it that every single cell in your body can become cancer, right? It's a strange thing because even your placenta, your heart can get cancer, your liver can get cancer, even the placenta can get cancer. Every single animal, every single multicellular animal that exists practically can get cancer. Like, why is that? Because it's so fundamental, because that's actually the time when we evolved from the single cell to the multicellular organism. So that seed of cancer actually exists in all of us. And the data to support this is, like, honestly, it just blew my mind, because what they did was they looked at all these genes that cause cancer. And they said, they didn't say, what are these genes that cause cancer, right? Gene this, gene this, and this. What they did instead was they divided them according to when these genes developed in evolutionary time. So they divided them into sort of these phylostrata. So, and what they said is the genes that are being targeted in cancer, when did they arise? When did these genes arise? And what they find is that this big spike right at the junction of sort of unicellularity and multicellularity, and which is good evidence that this is the right track. It's an evolutionary ecological disease that develops to chronic inflammation, chronic sublethal injury. So no matter what kind of injury you're talking about, so whether it's inflammation or whether it's, you get something like ulcerative colitis, for example, chronic injury. And what happens? The rate of colon cancer skyrockets. Why? Because that injury is now acting as a selective pressure towards the evolution of this colon cell towards a more survivalist sort of way. And that programming to be like a unicellular organism is what's going to survive. And what's interesting to me is that the way you have to think about it then is that cancer is actually evolving under this selective pressure towards a sort of foreign species, much like a bacterial infection. And you may say, well, that's ridiculous, right? It's not evolving into its own species. But you know that the immune system differentiates between self and non-self, right? So you have cells that are part of yourself and non-self. So bacteria are targeted by our innate immune system, that is, without being exposed, our innate immune system recognizes these bacteria as foreign. Well, they also recognize cancer cells as foreign, right? So it's like, it's not that big a stretch to say this is actually the evolution of a new species within our own body. And that is exactly how our immune system sees it. So the new paradigm, which is seeing this as a sort of a speciation event, that is, you've created this new species. Now, instead of trying to target the genetic mutations, which was sort of cancer paradigm 2.0, what you do now is you say, okay, well, if we have new species that are invasive, we need to uncover them. That's how we're going to treat them. And that's the whole promise of immunotherapy. And that's why it's so powerful, because you have these sort of sleeper cells of cancer cells, right? They're hiding in amongst the normal cells. They're trying to evade the immune system. Then you use these drugs, which are like the checkpoint inhibitors. So you uncover them and expose them. Or you do CAR T, where you actually engineer antibodies to these sort of foreign invaders, because that's the way the immune system actually sees them. So, you know, that's sort of in a nutshell the first part of what I talk about, which is this sort of change in the last few years. And I say it's such a fascinating topic to me, just because it's so new, and there's just so much to think about there, because the implications from a therapeutic standpoint are actually quite large. That is, the seeds of cancer are in all of us. So the only way to actually change your risk of cancer is to change the environment in which it grows, which is where nutrition comes in and some of these other things.
I think that's probably, this is absolutely fascinating. And I want to delve in. I took so many notes here. I think the idea of thinking about cancer like eroding your defenses, right? Eroding away at these natural barriers and defenses, right? Or a slow chronic insult to your body in the case of reflux, in the case of cigarette smoking, in the case of drinking alcohol, in the case of chronic poor diets. I think that becomes really scary for people, because I think it becomes scary for people because they don't want to consider the fact that their everyday food, their everyday breath, breathing in inflammation, or their everyday, smoking habit or everyday drinking habit, they don't want to think that these will have an impact. It's easier, in fact, to just shut that out and say, no, you know what, I'm going to live my life. And, and then 60 years later, somebody gets cancer, and sometimes it's inexplicable, right? And sometimes it is genetic. But I think it's easier for most people to put that lifestyle part out of the equation. Now, when you come back to it, I wonder, how difficult is it to look at the impact of lifestyle on cancer when 90% of people are smoking, are inhaling pollution from the cities they live in, when 90% of people are metabolically unhealthy, when 90% of people are in a society that's basically either overweight or obese, and very...
Yeah.
So how do you evaluate the true cause if the cause is the way we live?
Yeah, and that's really important, because, as you say, the chronicity is what's important, because this is an evolutionary process. So when you have an evolutionary process, you need a selective pressure sort of to guide that evolution. So just like the classic example in Darwinian, evolution is, he found this island and he found these birds, for example, and some of them had these really short beaks. They're great for eating nuts, and these other birds had really long beaks, which are really good for eating fruit. And the area of the island where there are a lot of nuts had a lot of these short-beaked ones, and the island with the part that had the fruit had the long-beaked one. And he said, that's not an accident, right? It's the environment which selects the genes that are successful. And that's why it has to be chronic. And that's why in cancer, for example, what you have is that you need chronic. So if you look at radiation, people were worried about the Hiroshima and the effect of Hiroshima on cancer. In fact, it had very, very little effect on later rates of cancer, because it was a single acute event. It wasn't a chronic exposure to radiation as you get with, say, radiation treatment for breast cancer, where you can get these radiation treatments for months and months and months. Same thing with hepatitis, for example. So if you have hepatitis B, hepatitis C, they increase risk of liver cancer, but they cause chronic liver damage. Hepatitis A causes a single event of very acute liver damage, and it's not associated with increased liver cancer. Same thing with hepatitis E. So yeah, what you have to have is this kind of chronic sublethal damage, which is exactly why you have to worry about diet, because that's actually one of the biggest risk factors. So this is what I get into in the second part of the book, which is, so the first part of the book is what I was talking about, which is how to think about this transformation event, how this thing transforms into cancer. And likely it's happening all the time. It's just that our anti-cancer defenses are so strong that we wipe it out most of the time. However, if you're immune suppressed, of course, with drugs or whatever, then you get an increased risk of cancer. But when they looked at, for regular people, what is what causes cancer? They did a study in 1981, and they sort of re-looked at it just a few years ago. And they said the conclusions are absolutely correct. And they do something called population attribution fraction, which is what percentage of cancers can be explained by a certain risk factor. So tobacco smoke was the biggest one. So 35% of the population risk of cancer is due to tobacco smoke. So really the most important thing you can do is not smoke. That's probably the single most important thing you can do. The interesting thing is that the number 2 cause of cancer in terms of population attribution fraction was diet at 30%. So 35% tobacco, 30% diet. Like, those two are in a class of their own. Everything else, like, pesticides and chemicals and pollution, like 1 or 2%, radiation, like 1 or 2% population attribution fraction. The biggest risk factor, other than tobacco, is our diet. And this is something that's absolutely fascinating, because we actually have some control over this. And so for years, people were like, okay, well, now we need to figure out why. Okay, so what part of the diet actually increases your risk of cancer? So the first thought was that fiber would decrease your risk of cancer. So the thought was that when you have these big bowel movements, you're going to move things through. The food is not going to sort of stagnate and, putrefy within the colon and cause colon cancer. So they did all these studies. Turns out that high fiber diets do not protect you against colon cancer. Then they thought it was dietary fat. So they did all these studies, finally came up with the Women's Health Initiative, where they did a low-fat diet. Again, no difference in risk of cancer. So it wasn't fiber, it wasn't fat. Then they thought, hey, maybe it's vitamin deficiency. So they did all these studies, again, big randomized trials on beta carotene, which is a precursor to vitamin A. They did vitamin B, they did folic acid, they did vitamin C, they did vitamin D, they did vitamin E, they did selenium, and they did omega-3s. And none of them made any difference. You could supplement people with all these vitamins, but they didn't reduce your risk of cancer in any way. So, basically what they came up with by the 2000s is that, one, diet is a huge part of what causes cancer. We know that because, again, diseases of civilization, you can move an African from his traditional diet into a sort of Western diet, and then he'll start getting cancer. You can move a Japanese woman in Japan to San Francisco, and her risk of breast cancer goes way up. We knew that diet was a huge part, but it wasn't fiber, it wasn't fat, and it wasn't vitamin deficiency. And, so then what was it? And the answer came around the year 2003, when it started. There was a huge study called the Cancer Prevention Study 2. And it basically tracked a lot of people who didn't have cancer over many years. It started in the 70s. And they tracked them. And in 2003, they said, well, we looked at this factor, and turns out it's a huge, massive risk factor for all different types of cancer. And that was obesity. So as the obesity epidemic sort of started going through the world, America and then the world, what we found was that obesity is actually a huge risk factor. And that was probably the most important thing. And it wasn't probably just the obesity itself. If you look at type 2 diabetics, they're at much higher risk. It's probably the hyperinsulinemia that's associated or causative, and that's what I think anyway, of the obesity. And that's, now the WHO classifies sort of 13 different cancers as obesity related. And the ones that are the most important are breast cancer and colorectal cancer, which are huge, right? They're sort of number 2 and 3 behind lung cancer. Like lung cancer has almost nothing to do with obesity. It has almost everything to do with smoking. But when you're looking at some of these things, we haven't figured out what causes them. Turns out obesity is very important. And it's more specifically, I think it's probably due to the hyperinsulinemia, because the biggest sort of realization of the last 20 years is that insulin is not just a metabolic hormone. It's actually a very incredibly powerful growth signal. So again, if you have a nutrient sensor like insulin, when you eat, it signals to your body that nutrients are available. You want your body to grow when there's nutrients available. So if you have low insulin, and then your body, if you're not eating, insulin goes low, your body gets a signal to please stop growing, and actually turns on the signal to start culling some of these cells, apoptosis and so on, right? So you'll actually shrink if you have no nutrients available. And this is important because if you have a cancer cell and you're giving it lots of growth signals, well, that's not going to be good. So breast cancer, for example, has about 6 or 7 times the number of insulin receptors compared to a normal breast cell. So it loves insulin. So breast cancer, colorectal cancer, these cells have so much insulin because they need to import all this glucose into the cell to use for energy. So it's an incredible growth signal. And in fact, there's a whole report of these dwarves in Ecuador called the Laron dwarf. They have Laron syndrome, where they actually have no IGF-1 or insulin-like growth factor 1, and they're basically immune to cancer. So Walter Longo was one of the doctors who went to Ecuador to study these guys. And so you turn off the growth signaling and you basically stop cancer sort of in its tracks. It's very remarkable. And this is an issue if we have a situation where we have more and more obesity, which is related to this hyperinsulinemia, which is increasing growth, which is now tipping the scales towards increasing cancer. So it's like, wow, that's a very powerful thing, because we can actually do something about it. Not in the short term, but sort of in the long term. If you're overweight, then you try and get to a normal weight. If you have type 2 diabetes, you need to try and reverse type 2 diabetes, because if the problem is too much insulin, well, you can do something about that, right? The foods that you choose have different insulin effects. And you have an intervention like intermittent fasting that is going to drop your insulin as much as you possibly can. So there are ways that you can influence this environment that are going to make it hard for this cancerous seed, even if it has managed to transform. You can make it very hard to grow. That is, just like the seed in the soil. If you have the seed of the cancer, which is in all our cells, and this has implications for screening and so on. This is one of the reasons screening has not been as good as we thought it would be. But if you have the seed of cancer in every single one of your cells, but you have sort of arid soil, it won't grow. So that's what you want to do. Unfortunately, the modern sort of Western civilization, the modern Western diet is plenty fertile for this type of growth.
Yeah, it's really alarming actually how much diet, specifically low carbohydrate diets, have been really shunned against into looking more. If you look into breast cancer, they're even exploring massive phase 3 trials with metformin to lower blood sugar and prevent recurrence. And yet the American Cancer Society says, you should eat more whole grains and avoid meat. So I think the problem becomes the messaging. The American Cancer Society has a very pro low fat, high carb approach to high starch approach to nutrition, and I understand how they got there, but certainly I don't think it's necessarily a low insulin approach. And if you consider that, we're literally testing in massive trials the use of drugs that would improve insulin sensitivity to prevent breast cancer recurrence, don't think it's a leap to consider at the least diets that would be less insulinogenic and would promote decreases in home IR and et cetera.
Oh, absolutely. I mean, there's people doing that right now, looking at ketogenic diets and so on. Unfortunately, these things are hard because the diet because it's a chronic thing, right? I mean, you develop cancer usually over 50 years sort of thing, right? So to do a 3-week study and try and pinpoint the causes is the real problem. And, you know, even if you look at something as powerful as smoking cessation, I mean, the effects took 10, 15 years to see. Like, you know, in 1960s when they said that smoking causes cancer, that's when you started to see the drop in cancer rates. And you didn't see the drop, that's when you started to see the drop in smoking rates, I should say. You didn't see the drop in cancer rates until sort of 10, 15 years later. So this whole movement towards sort of, that's what we're seeing now, which is that movement towards eating high carb foods. Remember the original food pyramid and stuff had bread and rice and potatoes on the bottom. That's what you should eat every day sort of thing. Unfortunately, I think now we're starting to get sort of reap the results of that, both in terms of obesity as well as potentially cancer. I mean, it's hard to say anything for sure, but it makes a lot of sense. And that's what, you know, this book is about, is really trying to understand cancer at a deeper level, to be sort of up to date, so that you can say, well, this is what makes sense. Eating sort of a diet that minimizes these refined sugars, refined grains, eating more whole unprocessed foods, and eating less frequently because you don't want to stimulate insulin like all the time. That makes sense because based on what we know about cancer and its metabolism and, you know, how it develops and how it progresses and so on, it makes sense to try to minimize it. So you can do something about it, luckily. You don't have to wait until the trials come out. I mean, you know, cutting out white bread and cutting out sugar is not that controversial, really. Eating 3 times a day instead of 6 times a day, again, it seems to be controversial in some cases, but it's like, you know, everybody in 1970s United States, like virtually every single person ate 3 meals a day with no snacks, and some of them less than that, right? And it's like, how is that controversial? Now people say, oh, you need to eat 6 times a day and stuff. It's like, well, why? Why would you want to do that, right? But but you're exactly right. I mean, that's the whole point, is that you can make these choices right now, which make a lot of sense. And you know, unfortunately, these sort of cancer societies and stuff, they take decades to sort of come around to see what should be obvious to everybody. I mean, they're always late. They're late on everything, right? It's like the whole fat thing, right? So remember in the 90s, we had this huge low fat. And then it wasn't until 2000, so throughout the whole 80s and the whole 90s, 20 years of this low fat. I don't know if you were practicing when we had these step 1, step 2 diets. I don't know do you remember those?
Remember them? Yeah.
They were horrible. So step 1 was, if you had a heart attack, you would go down to like 10% fat or something like that. And if you had another heart attack after that, you would go down to like 7% fat, right? And that's a really, really low fat diet. Turns out it didn't do any good, but that was a standard recommendation from the American Heart Association. It was ridiculous. Then, of course, after 20 years of this low-fat craziness, we started getting data to say, hey, look, Mediterranean diet's really good. It's actually quite high in fat. You know, nuts are really healthy for you, and they're really high in fat. Eggs weren't actually that bad. Hey, whole milk's actually not that bad. Like, all this data came out. So then they finally relented. And, you know, after everybody was way ahead of them, talking about healthy fats, right? Olive oil and avocados and fatty fish and fatty salmon, you know, like 10, 15 years after that, they start to say, okay, well, fat's not so bad. And like even now, the dietary guidelines are like, oh, limit saturated fats. It's like, oh, you guys are so far out of date. And unfortunately, we can't always rely on that, because if you simply rely on them to say, you would have been so far out of date and suffering all the effects of eating this sort of ultra low fat diet that was, you know, orthodoxy, nutritional orthodoxy for decades and decades. So these sort of things sort of make sense. And you can, you know, luckily you don't have to wait for them. You can do these sort of common sense interventions and hopefully regain a normal weight and hopefully reduce your insulin so that you don't put yourself at risk of these diseases.
You know, I have two questions for you. You know, some of the criticism I've heard against meat eating, you know, one of the criticism is, look, you know, processed meat has the same odds ratio when you look at epidemiologic data as smoking, or secondhand smoking, sorry. You know, you know, people have said to me, well, would you ever recommend secondhand smoking to anybody like you recommend meat? And I found you know, I'll tell you personally, you know, my response to that is, you know, if the meat eating leads to a decrease in obesity, a decrease in diabetes and blood pressure, then, you know, it may be a net benefit. But I wanted to hear your take, because I know when I read Longevity Solution, you know, it seemed to say, hey, let's incorporate plants as much as meat. And, you know, I'm sure in the cancer code, you probably tackle the issue of meat. So where do we stand on meat? You know, what should I walk away from this? You know, what's the take on meat? It's tough. It's high in protein. You know, it's funny. I have a joke. The oncologist says eat low protein. The cardiologist says eat low fat. The obesity doctor says eat low carb.
That's true, actually. I think that the data with meat, and it's kind of controversial, mostly lies with processed meat. And I think that's the real crux of the issue, right? The processing, I think, is really what's bad, not necessarily the meat. So if you eat meat, I think that's okay. But if you eat processed meats, you don't know how they process it, right? When they talk about processed meats, they're not usually talking about, you know, like Serrano ham from Spain sort of thing, right? They're talking about bologna, which is full of garbage. Like, if you ever read like the ingredient list,
and nitrosamines, and you know,
yeah, it's horrible stuff.
You know,
yeah, and it's like mechanically separated chicken and stuff. Like, there's stuff on those ingredient lists which actually make no sense at all. Like, it's really like it's obviously some really nasty stuff in there that they don't want to tell you about, because it's like, you know, beef parts that you really don't want to know about and stuff. It's bad. Yeah. So if you look at sort of processed meats and say, well, is it the meat or is it all the processing that it goes through to make it edible? Because, you know, the stuff is cheap. So they take the worst cuts possible and throw it all in, and then throw a bunch of chemical in to make it sort of edible, and chemical to make it pink so that it's not like, you know, unappetizing brown sort of thing. So there's a lot of stuff that goes in there. And I wish I had an answer, but I actually don't think meat is a big problem. I think that the biggest problem is the processing. And I think that's actually true for a lot of things. So when you process stuff, you take it away from the natural source. And I don't think this is limited to meat. So processed meats, I think, is bad. I think processed oils are bad too. So a lot of the seed oils, even though the data is sort of here and there, the seed oils, you know, those are not natural, right? You take corn and you process the hell out of it, and then you get corn oil, right? And that's not a natural product. So then we know about omega-6s and omega-3s, and maybe the omega-6 to omega-3 ratio is way off, which is causing a lot of inflammation to a lot of people. But it's not the oil necessarily, it's the processing. It's not like oil that's necessarily bad, because avocados and olive oil are not so bad. But those are natural oils, right? You take oil, to get olive oil, you take olives, you squish them, and you get olive oil. That's it. You can't do that with sunflower or corn or cottonseed. Like, cottonseed is not even a food. Like, you know, right. Cottonseed so cottonseed oil, which is Crisco, so that's sort of solidified cottonseed oil. It's like, you don't eat cottonseed. It's not a food, you know. The reason they have cottonseed oil was that it was garbage. So they were making all this corn in all this cotton in the American South, and for every pound of cotton, you had 2 pounds of cottonseed. And it's basically garbage, right? It's toxic waste. You have to get rid of it. So instead of doing that, they decided to process it, get the oil, and then say, hey, this looks like something that somebody might eat. So let's just sell it as food. And this was 1907 or whatever. So they're like, yeah, no problem. We'll just sell it as food. It's like, it's from cotton seeds. You don't eat cotton seeds. And it didn't kill anybody. So they said, hey, okay, let's just keep going. So that's how the vegetable oil sort of got its start. It was because it was cheap, not because it was good for you. And of course, the American Heart Association took a lot of funds from, you know, the seed oil makers. So I don't think it's necessarily just the meat itself, but the processing is bad. It's bad for fats. When you process fats, like when you get trans fats, we know those are bad for you. They might be fat, it might be low carb, but it's not good for you, right? It's processing. And when you process carbohydrates, you get the same problem. That is, when you take something and you take away all the fat and the protein and the fiber, and then you get pure carbohydrate like wheat, like bread. That's bad for you because your body can't handle it as much. So I think that it's not so much the meat, but the processing. I mean, I don't get into it that deeply because it's so sort of, there's no real answers there other than some epidemiological evidence, which is very, very weak. I mean, it's not strong data.
Yeah, and you know, the other question I had, you know, I found that a lot of times when you have a cancer patient, they come to me with a lot of questions, and they're like, should I do low carb to prevent recurrence? Or they say, should I do intermittent fasting to prevent recurrence? And I have to tell them, look, there's no data that took people and randomized them to one approach or another approach and measured the outcomes of cancer. But, you know, I think we have to use our best judgment. And it seems like both of these approaches, a real food, low carbohydrate diet, and a real food, you know, not eating when you're not hungry, it seems very intuitive. But there's a lot of cancer patient proponents, advocates and other dietitians who believe that, you know, you should not restrict any food for any cancer survivor under any condition. And so can you help me reconcile the ability to have very correct messaging to our cancer patients and prevention of cancer occurrence versus the strong bias that I feel is in American society says basically eat low fat, and the nutritionists basically say don't do fad diets, and cancer advocates basically say, you know, don't listen to Tro and Jason because they're quacks, you know, which is the truth. I mean, that's what they say. That's what they call us. And so what do you say to that? And I don't mean.
Well, I mean, I take much the same approach as you, which is that one, you know, I'm a clinician, so I deal with people and I have lots of cancer patients. So I get this question too. And you have to say, one, there really is no evidence. So we don't really know, like, as much as we like to pretend. Fasting has no support, but neither does just eating whatever, neither does the low-fat diet. Nothing has any kind of evidence base behind it. So it's not any better or worse than anything else. It makes sense for certain types of cancer that are very reliant on, say, insulin to eat a low insulin type of a diet. I mean, that is sort of logical, but I can't say with any certainty that that is going to be true. Even when you have cancer, like if you're fairly advanced, then you know, you need to take the treatment. I mean, they've spent so much money determining the best treatment that you should take it. You shouldn't, you know, I always say, do whatever your oncologist tells you to. If he says, do this drug, and this drug, do that drug, that drug. Like, don't just say, I'm not going to do it, I'm going to do fasting instead, right? You have to do what they tell you to. But in addition to that, there may be a role in eating a healthy diet to prevent recurrence. It's not going to kill your cancer because that you need much stronger stuff than your diet. But in certain cases, you can help it by eating a reasonable diet. I mean, these, you know, and I think they think that, you know, all we do is say, oh, eat meat all the time and stuff. That's not really what we're talking about, right? We're talking about eating real foods. We're talking about cutting down sort of processed foods and sugar for the most part. And I don't think that's you know, honestly, if you look at the message we give, it really shouldn't be as controversial as all that. Sometimes they sort of put us into this thing as like Tro and Jason said this, and it's like, and you look at it, it's like, I didn't say anything like that, right? It's like, there's somebody online, it's such an idiot. He's like, oh, Jason said that fasting is as good as chemo. I'm like, okay, can you please find me the place where I said that? Because I have never said anything of the kind, right? So you have to sort of, you know, I think you have to have a realistic idea of what the science is. Then you can make some reasonable suggestions like eating real food, cutting out refined foods. And if you're overweight, then yes, intermittent fasting may work. If you're losing weight like crazy because you have advanced cancer, then no, fasting is probably not the best thing in the world for you. I agree with that. If you're like 90 pounds and dropping, you know, dropping pounds fast, well, sorry, you don't want to be doing that. Like, because advanced cancer can do that. You get this cancer cachexia, for example, that where you do drop weight very quickly. And it's like, no, you shouldn't be doing any kind of restrictive, highly restrictive diet because you're losing weight like crazy. So you have to really take the science and sort of apply it to an individual patient. But having an understanding, I think the problem is a lot of people, they actually don't have any understanding of what the science actually is. They just take whatever somebody says and says, well, you know, this society said you should eat 6 times a day, so that makes sense. It's like, can you please show me the data that says 6 times a day eating is more beneficial than 3 times a day eating? I think it's much worse, but, you know, show me the data. They of course have no data, right? Or show me the low fat data. Like, it's just not there, right? It's, you know, and these things are, you know, even though they're logical, it takes a while to break through to, you know, to people who are getting the message sort of day in, day out, you know, that you have to do this, you have to do this, you have to do this. So, you know, cancer is a really sort of emotionally fraught issue. So that's why it's really tough. But I think the stuff that we recommend should be considered fairly, you know, fairly non-controversial.
Yeah, non-controversial and benign. I got 2 last questions for you. I know we have to go soon. Okay, so you're a nephrologist and you you're writing a book. You've written several excellent books and now a book on cancer. So nephrology and dabbling into some topics on oncology. So very clearly, if I had to typify you, I'd say you'd be in the low protein camp. But let's just say I had to put you into one. You had to make a choice here. Okay, you can either tell society to go low carb, low fat, or low protein, and it had to be one. Okay? It had to be one. Okay, our current world, our current society, low carb, low protein, low fat, had to be one. Which one would you say?
I have to go with low carb. I think it makes the most sense to me from a lot of different angles. You know, the whole low fat thing, I think, has been tried and very unsuccessful. So, and unfortunately, protein sort of caught the downdraft too from the low fat. Like you tend to wind up going lower protein, and so I think that's already been tried. So I think that, you know, the low carb thing, I think, makes the most sense.
Got it. You know, I was just curious because, you know, nephrology and oncology, very commonly our colleagues say, you know, hey, consider with fasting, keeping the protein low. I've just seen that, you know, anecdotally. All right. And I got, you know, one last question. You know, to what extent do you think, you know, environmental exposures, the, you know, contaminants in our food or the contaminants in our medicines or the, you know, cookware that we use or the, you know, air that we breathe, to what extent, I mean, we always talk about nutrition, but, you know, a lot of times we don't think about the chemicals we smear on our skin, the stuff that absorbs in our sunscreen and the methanol in our Purell, you know, solutions. And so, you know, when we're talking about the chronic exposure theory to cancer, to what extent do you think all these other things play a factor? And do you think it's something that people should think about or focus on, or, you know, stick to diet first and then move to these things?
Well, it definitely plays a role, but when you look at sort of the global sort of how much of a role does it play? So, because any type of chronic damage or chronic inflammation is going to be carcinogenic. But if you look at the overall sort of population attribution fraction, those are sort of like 1%, 2% compared to diet, which is like 30%, or tobacco smoke, which is 35%. And that's why tobacco smoke, nothing's really, I mean, asbestos probably is the next one, but nothing really has come that close to being that level of carcinogen in our population that we can identify. You know, some viruses, of course, are carcinogenic too, but you know, whether it's the sunscreen, the parabens and all this sort of stuff, the pesticides and the herbicides and stuff that we eat, it's probably a much smaller proportion than diet overall. So you're talking sort of like 10 times, diet being sort of 10 times more important, because this is stuff that we take in much higher quantities than, say, you know, the Purell or the sunscreen or whatever, because we're putting in, you know, large amounts of this into our body all the time. So therefore it's just going to have a much higher effect, just like tobacco smoke. I mean, that's a lot of smoke, like pack or a pack and a half a day sort of thing. I mean, you don't hear that much anymore, but I used to have patients, you know, 2 packs a day. Okay. You don't see it so much anymore, but you know what I mean? It's the volume, because it's the chronic exposure, and obviously our exposure to foods is going to be much higher than our exposure to these other things. So in terms of how much of importance, I mean, this has been studied, it's just way more important. That's why you need to think about it. Like, it's not that it's not important, but diet is just the dominant factor here.
Yeah, a lot of times I've seen people say, I'm going to go organic, I'm going to get new cookware, I'm going to get a HEPA filter, I'm not going to use sunscreen in there, and, you know, eating M&Ms and donuts and Krispy Kreme, you know. So it's like, I agree with you. If you're going to focus on that stuff, make sure you have your house in order first.
Exactly.
Absolutely. Listen, thank you so much. This is I'm excited for it. I'm absolutely excited for it. Thank you for coming on again. And it's always, you know, when the teacher speaks, the student listens. So this was absolutely amazing. I appreciate you coming on. And when is the book available? I'm guessing Amazon, Barnes and Nobles.
Yeah.
Get it.
Yeah, you can get it anywhere. It's available November 10th. So yeah, check it out. I'm really excited about this one, sort of more than most books, just because I find the topic itself just incredibly interesting. You know, not necessarily that, you know, in line with what people expected, but something a little bit different and really, really interesting to me.
Cool, and I love it that you're continually learning. You know, it's not just you know, here you are, you know, practicing nephrologist, world-renowned author, and here you are still delving into things that are a little bit outside of the toolbox. And I really hope that other people can, you know, especially the med students and the residents who listen in to the podcast, they realize like lifelong learning is what it means to be a physician. You know, and I think that's just setting a great example for you know, all the students and residents and other doctors that are listening in.
For sure. Thanks so much, Joe.